All right, we are starting back on part 2. We left off on slide 55 for everyone keeping track at home. Let's get back into it. Part 2, starting with thyroid and adrenal. By the way, this whole presentation, this second part, is going to be kind of a grab bag of things, so apologies, but just kind of the nature of things. I know in the past, students have I've gotten confused with some parts and kind of gotten mixed up with categorization and how to organize things. So please, organization is going to be really important for this module, and in particular this 2-part lecture. And I've tried, based on feedback from last year and the year before that, I've tried to kind of simplify some things, and I took some slides out that I had before that I think were confusing. So hopefully I made it less confusing and not more confusing, because that's happened to me too before. But anyway, so first off, just a little bit of background. Thyroid hormones, related drugs, functions of the thyroid. This is what they do. Just kind of review pathophysiology. Don't worry about memorizing this for my exam. This is just an overview here of showing you what's going on. Pathology here, this is just going to be kind of an FYI, but basically if you have too much, it's hyperthyroidism. And if you don't have enough, if you have a deficiency, then you have hypothyroidism, but you'll be learning a lot more about that in pathophys. Same thing here with this slide, just FYI for my course. More FYI and even more FYI and some more FYI. Okay, this is a good slide. I would look at this. Don't worry about memorizing the slide, but definitely read through it. This is going to be drugs that can cause hypothyroidism, drugs that can cause hyperthyroidism, and then drugs that can affect or cause changes in the thyroid function test. So this slide is important for pharmacology, but I'm not going to pull test questions here as far as I don't want you guys to have to memorize this, but definitely spend some time looking through it, reading through it. It won't hurt your clinical knowledge, and then won't hurt for rotations and then for your board exam. Another slide too that is, again, I'm not going to make you guys memorize it, but this is, I thought, important, that there's factors that increase the requirement for T4, so you'll notice there's some on there. Again, just this is an FYI table. Actually, out of these two tables, I think this table is more important for you guys to make sure you read through. Now to the drugs, Levothyroxine, which is actually T4. This one is just FYI with the pharmacokinetics, is that it may take a while to have the full therapeutic effect when you're initiating the patient on the levothyroxine. So just be mindful of that. It is used for hypothyroidism, so thyroid replacement therapy, and to help bring the patient's TSH level up to normal range, hopefully. It also can be used for pituitary TSH suppression. Adverse effects there, you'll notice there's a list of those there. Usually pretty well tolerated, but it's really going to depend on the dose, and then the dose that you're administering to the patient, and then also the specifics, or the specific patient. But definitely go ahead and read through those. The other thing to note too is this medication is one of the few medications that cannot be automatically substituted, or rather it should not be switched from brand name to generic. Majority of medications can be switched from brand name to generic with no problem. However, there are enough differences with the brand name, which is Synthroid, versus the generic levothyroxine, that is not recommended to switch back and forth. And you can actually notice some TSH or some of the lab levels will be different for your patients if they switch preparation. So this is one that they recommend just sticking with the either generic or brand name. Then we have T3, which is triiodothyronine. Triiodothyronine. All right, sorry, got a little tongue twister there. Drinking some tea, that's going to help me. This is synthetic T3, which is, the medication is called liothyronine. It is faster acting than T4. It's not usually used. It is converted to T4. They do make some combination products, but it's usually not used. So this one is used a lot less than the T4, than the levothyroxine. So that's going to be the main one you're going to be seeing being used, and then probably the main one that you're going to be prescribing as a practitioner. So, and then here is a table here that shows the preparations that are available here in the US. We talked about the levothyroxine, which is T4. You'll notice the brand names are listed here, and then the average adult dose, the liothyronine, which is the T3, brand name Cytomel. You'll notice its average dose there, and then they make mixture products, the Liotrix, and then the desiccated thyroid extract, which is the Armor Thyroid is one of the brand names of that one. So they make some mixtures. However, the majority of your patients, it is going to be recommended when you're trying to treat hypothyroidism to not use the combination, to just go ahead and use the levothyroxine, the T4. The combination T4, T3 may improve symptoms in selected patients. So for example, if someone has their thyroid removed or ablative with the radioiodine, so if it's completely gone, then that might be an instance where the combination should be used. And then the combination should be avoided in older patients, and then patients who have underlying cardiovascular disease. And that if you have, with those patients, if you have excessive T3 levels, it might actually cause arrhythmias. And then it's also not recommended to use the combination in pregnant women. So anyway, so typically, like I said, you're going to stick with the levothyroxine. It's going to usually be your go-to for hypothyroidism. If for some reason that the person does need to be on combination therapy, like I said, so if they've had their thyroid removed maybe, or if they had ablative therapy with the radioiodine, then you do need to be mindful about conversion. So occasionally we'll get questions in the pharmacy about converting. So this is one's from Up to Date, but they have conversion tables all over the place. So if you ever are going to switch somebody from a combination to levothyroxine, or you're taking them off levothyroxine, you're going to put them on a combination, just know that you do need to be mindful about the conversions. Don't worry about memorizing this for testing purposes. The conversion, this is more of an FYI, but it is something you're going to have to be doing out in practice if someone's going to need to switch. And then also for testing purposes too, just to go back on here too, make sure you know the generic names and you know which ones are which, but I'm not going to make you guys memorize the brand names, obviously, and then the average dosages I will not make you memorize, but all good information, and definitely read through it and study it there. Switching gears a little bit, we have the anti-thyroid agents, the thiamides. Specifically, we have PTU, the propylthiouracil, and the methimazole, two ones, and this one's usually referred to as PTU, I think, because it's easier and kind of quicker to say. So you'll see that, and you'll hear people actually refer to it as just PTU. These both are inhibitory. They inhibit the synthesis of T3 and T4, so they're anti-thyroid, right? Helps with ketoconazole. And specifically, this is what they are doing. So go ahead and read through that for the mechanism of action. But take home point, they inhibit synthesis of T3 and T4. Uses then, hopefully this is kind of logical or makes sense. They are used to treat hyperthyroidism, so overactive thyroid, usually in combination with the beta blockers, and we'll talk about those in a little bit more. But these are, going to be used for the hyperthyroidism. One note is the methimazole is longer acting than the PTU, so for longer term therapy, it usually is preferred. There's a couple caveats that we will get to here. Adverse effects here. You'll notice it's used for hyperthyroidism, so unfortunately, you can kind of overshoot sometimes and cause a person to have hypothyroidism when you're treating it. Hepatotoxicity is a rare but serious adverse effect to be concerned with, and specifically for PTU. So compared to methimazole, PTU has a higher risk of hepatotoxicity, and it does have a boxed warning, so that's definitely something you need to be concerned with and be mindful of when you're administering PTU. Leukopenia and agranulocytosis, rare but serious side effects. And then both are teratogenic. PTU is less so than methimazole, and there's actually a box warning related to that, and that I actually recommend. So that there are fetal abnormalities associated with methimazole. So the PTU should be the treatment of choice prior to pregnancy, during or just prior to the first trimester of pregnancy. But then because of its increased risk of liver toxicity, then they may prefer switching the methimazole during the second and third trimesters. So that's something that kind of, this is based off this these recommendations here. PTU, along with other medications, is also used for the treatment of the thyroid storm in pregnant women. So hopefully that's clear. There's been some confusion in the past with students. So I just pulled the direct language from the FDA warning. So this is the FDA US box warning that, so basically teratogenic effects more so with methimazole than PTU. However, PTU has more risk of hepatotoxicity, so you have to be concerned with that. So first trimester and prior to pregnancy, PTU. Second and third trimester, prefer methimazole, and then PTU can still be used for the thyroid storm in pregnant women. So hopefully that is all clear for you guys. If not, email me as always. Next up, we have the iodinated contrast media, iohexol and ditrazoate, a couple ones there. These rapidly inhibit release of T3 and T4. And I'll let you guys go ahead and read through the rest there. These are used to prepare a person to get their thyroid removed, and then may also be used for hyperthyroidism. Adverse effects, so a lot of adverse effects here. They actually can cause a thyroid storm too. They kind of, so anyways, just a lot of ones here. Just go ahead and read through all of those. They are all rare but serious adverse effects. So you note that they are all uncommon. And then just an FYI note that potassium iodine should be avoided with radioactive iodine is necessary because it blocks the uptake of it. So basically there's a drug interaction there. Radioactive iodine, abbreviated 131I. Okay, I had to change that real quick. For some reason it said 1311. But anyways, you guys will get the good slides. So a radioactive iodine is abbreviated 131I, or it's abbreviated I-131. So you can kind of see it either way. So so I just wanted to change that just so you guys are familiar with all the ways it's written. So 131I or I-131 or radioactive iodine. So this actually goes and it's trapped by the thyroid gland and incorporated into it. And then it destroys the cells of the thyroid gland. So its uses are for the ablation of the thyroid. And this is it with the hyperthyroidism, where they are non-responsive to your PTU and your methimazole and beta blockers. It can also be used for scanning purposes. And anyways, and it's for diagnostic purposes as well. So look through those. And then adverse effects, bone marrow suppression, angina, radiation sickness, rare but serious. And so those are all ones you have to be concerned with. Beta blockers are also part of the arsenal to treat hyperthyroidism. So part of your approach when you're treating hyperthyroidism, because with hyperthyroidism, you can have these sorry about that. Another typo. Took care of that. Your slides will be perfect. But these beta blockers will help treat the adrenergic symptoms that you can have with hyperthyroidism. So for example, anxiety, tremor, palpitations, all that good stuff. So those are can be beneficial and a lot of times are given in combination with that. And you'll notice down here, so this is a good summary table as usual. Go ahead and read through it. Clinical applications, adverse effects, contraindications. For the beta blockers, we have listed propranolol. So that was preferred historically, and there was some theoretical benefit of using propranolol. But nowadays, you can use atenolol and metoprolol. So, and usually the atenolol is the preferred drug of choice for treating the hyperthyroidism, or rather for reducing these adrenergic symptoms. So just put a quick note on there. Propranolol is not necessarily wrong. You still see it, and it was preferred historically, but now it seems like there's more evidence that some of the reasons that they thought propranolol was better, it turns out maybe it's not as good as they once thought. So anyways, so for testing purposes, beta blockers that can be used, and you just go ahead and write these on this slide or write them on this slide. We have the propranolol, atenolol, and then the metoprolol. So those are the three. And then of those, they now recommend, or guidelines recommend, that atenolol is going to be your first line beta blocker that's going to be used for to help with the symptoms of hyperthyroidism. So, and that's of course, you have to assume that there's no contraindications to the patient taking the beta blocker. So always be mindful of contraindications and stuff. But anyway, so hopefully that is clear and more up to date for you guys. And you know what? Why not? I keep forgetting that I haven't given you the, because usually I give these presentations and you guys already have the slides. So I have to like, hey, change this on your slide. But anyways, I forgot that you guys don't have these slides yet. So, so I added this here. So historically propranolol, so you may still see that being used. And there's not necessarily anything wrong with propranolol. It's not, it's just that there were some reasons where they thought it was maybe better. And then, yeah, it just turns out that it's not. And one of the reasons that atenolol is preferred is because of once-a-day dosing. But also, too, I've had students ask me about, well, could you use any beta blocker? So let's say emergency situation, or you're in the jungle, or there's, you're with limited resources. You could theoretically use any beta blocker. And again, as long as there is not a contraindication to their use. So, yeah, and just as a review, too, that there's the contraindication in patients. The beta blockers are contraindicated in patients with asthma or COPD, severe peripheral vascular disease, bradycardia, second or third degree heart block. So anyway, so yeah, those are some instances of where you'd want to avoid the beta blockers. But yeah, so to answer students' questions, could you use any beta blocker? Yeah, theoretically you could. These are just these are the three that are more preferred, and you'll probably see them being prescribed. But whatever, if these aren't on your hospital formulary or something, you can go with any other beta blocker. I think I've said enough about those. All right, switching gears here. So this is a good summary table, so go ahead and please read through that. Adrenal hormones and related drugs. All right, first off, we have the glucocorticoids, cortisone, hydrocortisone, methylprednisolone, and dexamethasone. These have very widespread effects throughout the whole body, multiple tissues and organs, which we'll see here in a little bit. Broken down, they have metabolic actions. So lots of stuff going on here. Please just go ahead and read through this. I know there's a lot going on here, and I don't want to just read all this to you, but yeah, so definitely look at this. Usually these changes are beneficial, but they can be related, or you may need to be thinking about this when you're thinking about adverse reactions or adverse effects rather, when you're administering some of these steroid medications. So yeah, and by the way too, so glucocorticoids are also referred to as steroid drugs. So you may hear me referring to those as steroids. It's a little bit easier to say than the glucocorticoids. So anyway, so yeah, the metabolic actions are generally beneficial, but they may be problematic and cause adverse effects. And then here's just a visual representation of the metabolic actions. There's also catabolic and anti-anabolic actions. So again, these usually aren't an issue unless a person is on higher doses for longer term. So definitely go ahead and read through all of these. This is where you do need to be mindful of maybe like the Cushing's syndrome, so specifically osteoporosis is secondary. Go back in part 1 and look at that slide ahead of where the Cushing syndrome with those adverse effects, if you want to be reminded of those. But anyway, so these can be problematic, but usually this for short-term low dose, and then like for some of the topical products, you don't have to be worried about this as much, but definitely longer term, higher doses, you do need to be mindful of these. CNS actions are also potential. Behavioral disturbances is a big one. So these medications, so these steroids, glucocorticoids, need to be used with caution in patients who have psychiatric conditions. So it doesn't mean you can never use it, but again, with higher doses, longer term, you need to be mindful of the psychiatric implications, as well as maybe intracranial pressure, etc. So go ahead and read through this. There's also some EEG changes, so that may also have an effect depending on what's going on with your patients. Anti-inflammatory and immunosuppressive effects. So these are This is a big reason why they're used therapeutically. This is a big reason why you'll be prescribing them and why you've seen them being used, is because they have anti-inflammatory and immunosuppressive properties. So please go ahead and read through this slide. There's a lot going on here. This is also, again, with all of these effects of these medications, you also need to be thinking about adverse effects, and so they're good and bad. It causes, they're anti-inflammatory, they're immunosuppressive, which can be good, but then, like, for example, you're treating a skin disorder, and you think and you're trying to reduce inflammation, but then because it's immunosuppressive, you actually, can make the infection spread. So, for example, if you have a fungal infection on your skin, you put hydrocortisone on it, which is a type of topical steroid. You put hydrocortisone on it, and you can actually make the fungal infection grow and spread because the medication hydrocortisone is immunosuppressive. So anyways, there's also miscellaneous actions, which are important. Please read through these as well. So related adverse effects, peptic ulcer, so that can be an issue. These other ones here are going to be, again, with higher doses, longer term. So something that, again, you have to think about with that. Uses here, substitution therapy and adrenocortical insufficiency. So that when that happens, non-endocrine disorders, which will be here on the next slide. So allergic reactions, just read through this. There's a ton of stuff. A lot of these non-endocrine disorders are related to inflammation. And so it's when, like I said, because they have these medications have anti-inflammatory properties, you notice that there's a lot of uses there. Also, to kidney transplant. So because they have immunosuppressive properties, they can be beneficial with organ transplantations. So definitely please go ahead and read through this slide and go and add it to this use slide. Also used in asthma, which we saw before in previous module. Immunosuppressive therapy, and then some diagnostic functions as well. But this is definitely a good slide. You don't necessarily have to memorize it, but yeah, I mean, I would want you guys to know this. I meant memorize this table just, throughout, but definitely the take-home point for this, I think, is important, is that, you read through it and then make sure that it can be used pretty much all over the body, topically, different organs, eye, for allergic reactions, etc. And because of its anti-inflammatory and immunosuppressive properties. So definitely it's a good idea to read through that. And then, like I said, some of the stuff we've already seen, COPD, asthma. So definitely put a star on this one. I think this is good to pay attention to, good to study when you're thinking about these drugs. Adverse effects. So this is also important too. For testing purposes, so put a star here too. But we have the adrenal suppression that can happen because of negative feedback, because you're giving exogenous hormone, right? These glucocorticoids, the body reacts to them like it would its own. So when you're giving it externally or exogenously, the body has a negative feedback mechanism and it regulates itself, right? So then and that's why they don't recommend abrupt discontinuation. They typically recommend that when the therapy is discontinued, it must be tapered. So that's why I have this slide here. This is methylprednisolone. So this shows you that the day 1 you start with these 6 tablets, day 2 you take 5, then day 3 you take 4, etc. And this is, you slowly taper off, and this is because and this is because you are discontinuing the external or exogenous supply of steroids, and you want time and to allow your body the ability to recoup. So hopefully that makes sense. So yeah, tapering off then will basically let your body to readjust to being off of this exogenous steroid. So that's why they taper it off. Other than that, you can have a Cushing syndrome as an adverse effect, which is going to be huge here. And so the Cushing syndrome, like I was saying, is a big deal. I just went ahead and added another extra slide for you guys to help you with, remind you. So you go to the next slide then. The Cushing syndrome is what we're talking about when we say that the adverse effect can be Cushing syndrome. So that this is something else that you'd be concerned with when you're prescribing steroids. And again, it's usually higher doses, longer term, and it's inevitable. So if a person needs to be on high dose long-term steroids, they will develop the Radioactive Cushing syndrome. So that is something that you need to be mindful of. Also some metabolic effects. So metabolic alkalosis is something to be concerned with. Hyperglycemia is an issue, and that can be in particularly problematic with your type 2 diabetics or with anyone who has diabetes mellitus. That's something you think about. Hirsutism also in women. Hypertension is another issue that you need to be concerned with, and that's because of sodium retention. And then these medications actually can cause diabetes mellitus. Diabetes mellitus, just again, secondary to being on it. Usually, again, it's longer term, higher doses, but that is something too that, so this is another important slide. So definitely put a star by here. And related to that slide is definitely include this for studying purposes when you are thinking about these exogenous steroids that you're prescribing and that you do have the potential for Radioactive Cushing syndrome. And there's a dose taper there, so hopefully that helps you as far as visuals. More adverse effects, increased susceptibility to infection. I mentioned that because it is immunosuppressive, that you do have an increased susceptibility to susception. So put a star on this one too. So put a star on any adverse effects slide for testing purposes for the steroids. PUD, so peptic ulcer disease. We talked about that a little bit earlier as far as how it up here. It suppresses local immune responses to the H. pylori, so you have increased risk of PUD. Musculoskeletal effects, the osteoporosis is an issue, and especially for older women, you need to be mindful of that. Behavioral disturbances, I talked about that specifically for psych patients. And then there are some ophthalmic effects as well. So the visual impairment, which is not good for anybody, any of your patients. Next up, we have the Mineralocorticoids. Aldosterone is the most important naturally occurring hormone. And then the fludrocortisone is the oral synthetic that actually has mineralocorticoid and glucocorticoid activity. However, when it's dosed at, you only have to be worried about the mineralocorticoid effects. So this is how it's synthesized excrete. Just read through that. Mechanism of action, increases retention of sodium and water. So if you have too much, then you have produces hypertension. And then it increases the excretion of potassium and the hydrogen protons. So it is used then for Addison's disease. It can also be used for salt-losing adrenogenital syndrome, and then it can also be used for adrenal insufficiency in combination with hydrocortisone. Next up, we have a table here that I think is good because it shows that the duration of action can vary with these steroids, the glucocorticoids, and then the relative potencies can vary. They're all compared to cortisol. So cortisol was given a arbitrary value of 1, and then everything is compared to that off that. So you'll notice there are short-acting, intermediate-acting, long-acting, and then we have the mineralocorticoids down here at the bottom. And we have RGP and RMP, and then the duration of action. So please, for testing purposes, make sure you know which ones are which as far as short-acting, intermediate, long-acting, and then the mineralocorticoids. And then RGP is the first column here, which stands for relative glucocorticoid potency, and again, that's compared to cortisol. So you can think of that as being its anti-inflammatory activity. So you notice here, the higher the RGP, the more anti-inflammatory it is. So just a heads up too, I've had students in the past bring me other tables. So these tables can be organized in different ways. So they sometimes are organized by their anti-inflammatory properties. So if, for example, the beclomethasone and dexamethasone would maybe be on the top of this if they were going by most anti-inflammatory to least. And so I don't necessarily want you guys to get hung up too much on the table organization, but definitely, duration of action. Is it short acting, intermediate, long acting, or is it a mineralocorticoid? And then the anti-inflammatory properties. I definitely want you to know which ones are stronger anti-inflammatory glucocorticoids versus less strong or less potent. And then RMP is relative mineralocorticoid potency. So you can think of that as being sodium retention. So you notice here on the RMP, and definitely aldosterone is going to have your most sodium retention there, and be, biggest concern with that. So that has the highest RMP. We also have topical corticosteroids. So these are grouped according to their anti-inflammatory properties. So not exactly the way it's lined up out here on this table. So again, hopefully it's not confusing, but so these are grouped according to their anti-inflammatory properties: high, medium, and low. Low potency, you can get some of these over the counter, hydrocortisone. So the other ones are prescription only. And these low potency are supposed to be used, or best to be used, in the more sensitive parts of the body, so face and eyes, because as a general rule, all of these topical corticosteroids have the adverse effect of they can cause problems with the skin. In particular, they can cause thinning of the skin. And so it's something that you need to think about if you're going to prescribe topical steroids longer term. But then, so with the thinner parts of the skin, the more sensitive parts of the skin, you definitely want to go with the lower potency. Then we have the low to medium potency, triamcinolone, fluticasone. This one you can use on ears, trunk, arms, legs, and scalp. And then the medium to high, it's definitely should be used for the thicker skin, so palms and soles. Another thing, just a note, just more an FYI thing, that we have, there's different vehicles of administration. So we have ointments, lotions, creams, lotions, and gel. Ointments are typically for dry, cracked, scaly, or hardened skin. So like palms of your hands, maybe the soles of your feet, or, elbows, or, just kind of depends on the patient too. Lotions and creams, typically for moist weeping lesions, conditions with intense inflammation. They're kind of more soothing and cooling. Also, the lotions and gels can be, there's also lotions and gels, and those can be more convenient for hairy areas. So again, just kind of depend on the patient. I've had students ask me about if you have to administer both. They typically, it's going to depend on the patient and the dermatological condition. But if you do need to put these, a lotion or a cream and an ointment on in the same area, they typically recommend, putting the cream on first, waiting, 30 minutes or so for absorption, and then putting the ointment on. And then some, with some of these products that they make commercially available together, the patient can mix themselves. But I had students ask, I think the student was on a dermatology rotation, but dermatologists are a great source for all this topical stuff. So you guys maybe see that on your rotations. Then we have a summary slide here, so please go through this. We have all the steroids here, and we have the clinical applications, adverse effects, and then the contraindications. So please read through all those and make sure you're studying those for the exam. This is a good table too, but I'd put a star there on this slide. All right, changing gears here and kind of getting to the sunset of this presentation, or the ending point of it. We have antagonists of adrenocortical agents. Here is the list here. First off, we have Metyrapone. So this one is used for Cushing's syndrome. Just FYI on this one, don't worry about it too much for studying purposes. I mean, definitely read through it. But next up, we have another medication that's used for the Cushing's syndrome, the Aminoglutethimide. Read through the mechanism of action there, but just know with these drugs, just know where they're classified and what they're used for. So this one, be able to pick out that it's used for Cushing's syndrome. This one as well. Ketoconazole we've seen before, it's an antifungal agent, but then please also note that it can be used for Cushing's syndrome and for prostate cancer. Mifepristone, which is also known as RU486, which is also known as Mifeprex, it's one of the brand names, can be used for Cushing's syndrome specifically to help control hyperglycemia secondary to hypercortisolism in patients with endogenous Cushing's syndrome. So anyways, that's what... Mitotane, this one is, again, not a super common medication, but it can be used for cancer, so specifically adrenal cancer. And then last but not least, we have the mineralocorticoid antagonists, spironolactone and epilerone. These both inhibit aldosterone, used for hypertension, which we saw in previous modules, usually not first line, but usually in combination with other things. It can also be used to diagnose and treat hyperaldosteronism, and also help treat hirsutism, which is, by the way, hirsutism, I don't know if I mentioned this before, it's abnormal, kind of undesirable overgrowth of hair. Also can be used for ascites associated with cirrhosis, and then severe congestive heart failure, but again, not usually first line, and definitely go back to previous modules for where it falls there. And that is it for me. Thank you guys for your time and attention. Hopefully these presentations were less confusing than they were for the students last year. So as always, please email me if you have any questions, comments, or feedback. And if things were super confusing or whatever, I'm really sorry. But this is just kind of what happens with this module. And maybe it's just me too, because like as a student, it just wasn't my favorite thing. But anyway, so hopefully this wasn't too bad of a presentation. Thank you guys for your time and attention, and I will talk to you guys later.